we'd like to welcome Dr. Trevor Smith. You're supposed to clap. And I'm going to let him announce no one gave me his bio. I spoke with him and he's very nice, so treat him well. And I will let him introduce himself and his lecture. Thank you.
Thank you, sir. All right, I don't want to feel like I'm giving a church talk, so I'm not going to use the rostrum here or anything. Thank you, Dr. Johnson, and to the National Kidney Foundation for inviting me to speak. I believe this is my second time. Anyone who was here the first time, hopefully you didn't fall asleep, and that will be my goal today as well. The aim of my talk today is going to tie in with the theme of this conference, and that is lifestyle modifications for the kidney patient. So we talked a lot over the last 2 days about things that we need to be doing ourselves and things that we need to be inviting our patients to do. And one of my goals was to kind of look on the other side and understand what it is that our patients may need to change as a result of things that have happened in the past. And so my first working title was actually going to be Lifestyles of the, not the rich and the famous, but of the kidney patient. And for the younger generation, not MTV cribs, but the kidney cribs, again, to understand what it's like on the other side. As far as disclosures, I believe one of the doctors yesterday gave a similar thing that I am not a dietitian, nor am I an exercise sports scientist, although I'm going to be covering 2 of those topics, and then the requisite form, I'm not trying to hawk anything while I'm up here today. So, what I hope that you will take from the next 45 minutes here is that you'll be able to understand what are some of the things that we're asking our kidney patients to change about their diet, and a little bit of understanding as to why that is. I also would like to talk a little bit about exercise, and not only what is that going to do for our patients, but also what it might do to our patients. And then lastly, understand that chronic kidney disease is a life-changing diagnosis, and that there are some less thought about consequences of that. And so I want to talk about a few of those symptoms and some exciting things that are happening to help patients have a better quality of life while dealing with chronic kidney disease and dialysis, if not higher quantity of life. One thing to remember, and that I tell my patients all the time, is that there's no magic in what we're asking them to do. I don't have a special wand. I don't have a super pill. I don't have a magic berry that is going to make everything get better, and that it's really a commitment and a team effort between the patient, myself, as well as the other caregivers that they're involved with to help them be as successful as we can, understanding that what's happened is in the past and that we need to move forward with where we're at. First, with the diet, what I'm going to talk about primarily comes from the KDOQI guidelines, the Kidney Disease Outcomes Quality Initiative. And this was also in partnership with the Academy of Nutrition and Dietetics. This is the most recent update from 2020, and as you know, with guidelines, we're lucky if they come out once a decade. So this is what we're dealing with the evidence for the foreseeable future. And right out of the gates, what I want to talk about with that diet is that there was this very prominent recommendation here that patients should probably be working with a dietitian. Now, the official recommendation is that within the first 90 days of starting dialysis, once a year, or when indicated. Now, that is subject, I think, to interpretation of what indicated might mean. I think if patients have questions, it's really a great idea to get them in touch with a dietitian. That would be an indication, I think. The other indications might be if we suspect that they have aspects of malnutrition, undernutrition, etc. But really involving a registered dietitian, I think, can make a big difference, particularly in the early stages of chronic kidney disease. As far as assessing the nutrition, the guidelines go into a whole bunch of discussion of bioimpedance and DEXA scans and other things. When I talk to my nutritionist friends, however, they say, yeah, that's really nice, Trevor, but only high research facilities have this multi-frequency bioelectrical impedance, blah, blah, blah. Like, it's not really used in practice. Could it be? I suppose, but it's not anything I've ever used or that the dietitians that I work with ever use. But this is if you really need to know, you can find out, I suppose, with body composition and assessing for protein malnutrition and everything. Things that we might use more on a clinical basis are things like the body mass index. And with that, there's some interesting trends that go along with body mass index that you may or may not be aware of. The first is that in our patients with body mass indexes that are underweight, and if they're on peritoneal dialysis, they actually do worse. And there's some conjectures that doing peritoneal dialysis, you have a chronic loss of protein each and every time you drain the abdomen, and therefore you are further getting in the hole of the nutritional deficit, and that can lead to worse outcomes. And actually, conversely, on the other side, if they are overweight or obese, they actually do better on peritoneal dialysis. And again, I think that is that you're draining the sink, but you have a larger reservoir to deal with that. So an interesting association there. Next is that patients who are underweight or with morbid obesity do much worse with hemodialysis compared to normal weight or just grade 1 obesity. And then finally, in our transplant patients, they work really hard, they make, the lifestyle changes, and they, win the lottery, and they have that chance to get a transplant. Underweight, overweight, and obese all have a higher mortality prediction. So the hope is that they get the organ, and then that will help them kind of start fresh and start new on their journey to better health. Other things that we look at when it comes to nutrition in our CKD population are the labs. Dr. Morales and I were just commenting a moment ago that as nephrologists, that's what we love. We love to see what's in the lab tea leaves, and what's going on. And so, things like serum albumin, pre-albumin, and things like that can give us a picture of what's going on. But I'd like to caution you and remind you that that is not the end-all, be-all as whatever their albumin level is. Other things that you may or may not be aware of is in our dialysis patients, we can get a pretty good ballpark estimation as to how well they're doing with their nutrition by something called the normalized protein catabolic rate. And what we do is we take their labs at the end of dialysis and their labs at the beginning of dialysis, and we look at the BUN. And then with that, we calculate that by a cofactor and times that by the number of hours that they have had between their dialysis sessions, divided by 24 in a day, and that gives us a rough estimate as to what their protein intake has been. And then there are associations that if patients have a normalized protein catabolic rate less than 1, that they need to work harder on their nutrition, or that we need to work harder at helping them. If they're between 1 and 1.2, that they're getting there, but not quite there. And then lastly, if they're above 1.2 with this NPCR level, that they're doing well. If you ever want that calculation or need help, reach out to your friendly neighborhood nephrologist, and we'd be happy to help you with that. Now for this slide, I don't want you to memorize the form here. I know it's very small, and that's intentional. I don't want you to focus on that. What I want to focus on is that there are other global assessments that we can look at to get an idea of what a patient's nutrition might look like. And again, this is where the registered dietitian would play a role on our team, and they would go through factors such as, have they had any weight loss? What do the patients report their dietary intakes are? Do they have any GI symptoms like diarrhea, nausea, poor appetite? What's their functional status, etc.? And then the dietitians can put that together and come up with a composite score to say what kind of risk are they at for their nourishment, well-nourished, mild to moderate, or severely malnourished, and then again, that helps us target interventions for them. A different measurement, which again has some of my favorite things, laboratory parameters, also accounts for things like inflammation that can be measured in addition to those patient-reported facts. But again, at the end of the day, the one take-home point is, if you have any doubt, ask a dietitian. If you don't know a dietitian or you want a kidney-centered dietitian, ask your neighborhood nephrologist, and we'll help point you in the right direction or point your patients in the right direction. So what does that mean in terms of what our patients should be doing? We assess that they are malnourished and everything. What do we look at? Number one is going to be their protein intake. And so there's different levels of what their protein intake should be depending on their comorbid conditions. So for example, a patient not on dialysis, not having diabetes, they should actually have a protein restriction. And I want to emphasize that, a protein restriction. And that is a lot less protein than we might think. It's actually 0.55 to 0.6 grams per kilogram of ideal body weight. That means that our patients should not be eating a lot of protein. And why does that matter? The more protein they eat, the more organic acids they produce, and then the faster they progress to end-stage renal disease. So that is one of the big things that we can ask our patients to do, is restrict their protein. Now in our diabetics, the recommendations shift just a little bit. They're still asked to restrict their protein, but because of being able to keep their sugar levels and things under control, they actually are a little bit more liberal with a protein intake of 0.6 to 0.8 grams per kilogram of body weight. So again, if you can focus on that, if you can think about that in your conversations with your patients, restriction is where we want to aim. In our patients who are on dialysis, however, the paradigm shifts dramatically. Again, being on dialysis, having end-stage kidney disease is a very high inflammatory state. And so they are in a heavy catabolic state with their body, and so we need to actually double the amount of protein that they then get when they start dialysis. And so then you say, well, Trevor, that sounds a little bit bipolar, that you really drop it and then you ramp it up. Why don't we just shoot for a middle of the road? But again, we're trying to prevent things, try to keep them from getting on dialysis as long as possible. And this is a hard shift for the patients as well, when we've asked them to restrict their protein and then all of a sudden all they should be eating is protein, or at least that's how they feel. That is difficult. And so again, we involve our dietitian to help us encourage, give them recipes, give them suggestions, and that sort of thing. As far as the protein and the guidelines and everything, I know yesterday we heard at length about the power of plants, and I do believe in that, but as far as the kidney outcomes and things like that, there's no specificity on animal versus plant-based proteins, although there is a suggestion that plant-based protein may have phosphorus that's a little bit easier for our bodies to handle, and so some suggestion that aiming more for plant-based proteins would be more helpful. How about other supplements then? So if we determine that our dialysis patients are with low nutrition and everything, we ask them to supplement. Go to Sam's Club, go to Costco, go to wherever you can and get protein. And these are just a few examples of protein that can be available either on Amazon or the grocery store. And we try oral supplementation and see what happens to their nutritional state, see what happens with their albumin, see what happens with their energy, see what happens with their other laboratory values. If that doesn't work, then we have to start bringing in the hammers. That's when we talk about a feeding tube. That's when we talk about TPN, or in some extreme cases, doing intradialytic parenteral nutrition. And there has been some suggestions that adding amino acids to our peritoneal dialysis patients could theoretically be used, but the guidelines say maybe we ought to avoid that. But nutrition is key for our dialysis patients, and particularly protein nutrition. How about on to other nutritional supplements? I believe a question was asked yesterday about the benefits of omega-3 fatty acids. Well, from a pure kidney standpoint, it is not recommended for primary cardiovascular protection in kidney patients to take omega-3 acids. They say it's reasonable that if they have dyslipidemia, if they have high triglycerides, that you can consider that and just monitor your dosing. And then there's been all kinds of other debates about the superpowers of the omega-3 fatty acids, such as AV fistula or graft patency, or even protecting transplants, and the data, unfortunately, is not there to say that that's really helpful. How about vitamins? Utah's a pro-vitamin state. So what do we think about the vitamins? Well, first and foremost, if we can get it through whole-based foods, that's the way to do it. If we can't, a multivitamin might be the next place to start. And in, again, our dialysis patients, a renal vitamin, because it tends to be lower in potassium, lower in phosphorus, is the way to go. And then very specifically for any of the other vitamin deficiencies, folate, B12, etc., then we can supplement as needed and as the symptoms dictate. One that I want to highlight here, because this becomes a hot button issue, particularly in the winter, is about vitamin C. So again, if you can get vitamin C through the diet, that's a great way to go. As far as supplementation, though, these 500 milligram whoppers and other things is about 5 to 6 times higher than the recommended daily amount for patients with any degree of chronic kidney disease, stage 1 through 5 and on dialysis. The reason why is that vitamin C can increase the risk of oxalosis, and that can lead to kidney stone formation and worsening of their kidney disease. So be careful with vitamin C, emergency, any of those C things for your chronic kidney disease patients. Other vitamins, vitamin D, again, another hot button issue at times, only if deficient. And then the other thing to remember is that the kidneys are the primary source for conversion of 25 vitamin D to 125 vitamin D. And with broken kidneys, you have a hard time with that conversion. So often we have to supplement with other factors to keep their calcium and their phosphorus levels under control. Vitamin A and E, again, if you are supplementing, you'll have to monitor for toxicity because kidney patients are at a higher risk for problems with that. And then trace minerals, anybody who wants to throw some gold or some chromium or something in there, do so very carefully. Other things in terms of dietary acid. So I mentioned those organic acids that come from heavy protein use. We know that just from day-to-day life that higher acids lead to worsening kidney disease. And so there is a recommendation that first we should try and reduce the acid intake, which again, congruent with the other speakers from this conference, increase plant-based fruits and vegetables. And then if needed, add alkali supplementation. And that's where I put my friend here, Arm & Hammer baking soda. Very simple. Patients can do half a teaspoon or a teaspoon in 8 ounces of water, swirl that around, drink that twice a day, or if that's not too palatable, then they do make sodium bicarbonate tablets that they can take with a goal to maintain their CO2 levels of 22 to 28, which correlates with a normal blood pH most of the time. Calcium then, again, for our patients with stage 3 through 5 kidney disease, their recommendation is 800 to 1,000 milligrams per day. And that comes from all sources, their food, their supplements, any Tums or other binders that we ask them to take. So we need to be careful with that. And then once they do reach the time of getting dialysis, we monitor their calcium every month. We assess their medications and we adjust things as necessary. One of the big P's here, so phosphorus. Again, stage 3 through 5. Phosphorus comes from non-natural foods. So you'll notice the list here, soft drinks, fruit punch, beer, Cheese puffs, my kids particularly liked that one on the slide, that the cheese puffs are not good for the kidney transplant patients. If it comes from a box or a bag, they probably shouldn't be eating it. Post-transplant, however, they have a functioning kidney now, and their body has been on overdrive for a long time. So now we often have to supplement our patients with Nutrifos packs or other high phosphorus foods like nuts and beans and those sorts of things. So again, a different paradigm or way of thinking of that. Another one of my favorite P's, potassium. Obviously, potassium is bad. It can precipitate cardiac arrhythmias. It can precipitate muscle weakness and other things. We ask them to adjust their diet, and that's one of the hardest things. All my superfoods that I have at the top of my head, the avocados, the bananas, the cantaloupe, the beans, the nuts, the chocolate, whole grains. Everybody says, well, my goodness, like what on earth can I eat? So that's when I typically go to the National Kidney Foundation website. I just Google that. I say kidney.org, spacebar, potassium. And then they have a great handout on potassium in your diet, and it gives a list of high potassium foods that you can counsel patients to avoid, and low potassium foods to give them suggestions of things that they can buy at the grocery store instead. Just as a quick example, for patients who eat a lot of bananas or oranges, they can substitute those for berries or grapes. If they drink orange juice, you can ask them to switch, probably just water, right, based on the information that we've heard. But if they have to have a juice, apple or grape juice is lower in potassium, etc. And then if we really don't succeed with that after a good try, or the patients are really in danger, we do have medications to help bind or lower the potassium, which is the Veltessa, the Localma, or good old K-Exolate. And yes, I still do use K-Exolate from time to time because it's a lot more cost-effective than the Localmas and the Veltessas of the world. And then often we'll have to have patients on diuretics to help with their potassium management as well. I want to end the talk on nutrition on the enemy of nephrology and probably cardiology, and that is sodium. We eat way too much sodium. I don't need to tell you that. But I wanted to point out a couple of interesting studies that have recently come out. So in the New England Journal of Medicine in 2021, there was a study published called the SAS study. And what they did is they looked at 600 rural villages in China, and they asked them to make one change. They took away their salt shaker, and they gave them a salt substitute. That was a combination of potassium chloride and sodium chloride. And just by doing that, they were able to reduce the incidence of stroke by 14%. They were able to reduce major adverse cardiovascular events by 13%. Deaths from any cause by 12%, all with very minimal hyperkalemia noted in the patient group. And then in the heart meta-analysis that was done, this was a total of 31,000 patients in this meta-analysis, 21,000 of which came from this SAS study. And again, with the heart meta-analysis and things like that, they found that their results were concordant with the SAS study. No brainer, since that contributed 2/3 of the patients, right? Anyway, salt, that's the enemy. Cut it out if you can. Use a salt substitute. That's as good as any medicine, honestly. All right, on to exercise now. Interestingly, Americans don't exercise. Shocking, right? In our dialysis patients and our chronic kidney disease patients, it's even worse. So when they did a survey of chronic kidney disease patients, they were reporting about 9 days per month of any type of physical activity. And in the dialysis patients, nearly half of them said, I don't do anything. Well, some of that could be attributed that they're in dialysis half the time, but even in their free time, they're not moving enough. So what if we get our patients up and moving? What does that do? Well, first, the KDIGO guidelines. So in treatment for blood pressure, the KDIGO guidelines from 2021, it said we recommend 150 minutes per week. But there might still be important benefits even if they can't get to those targets. Something is better than nothing. In a meta-analysis, there was 13 randomized trials, and what they showed was that by exercising in chronic kidney disease, we could maintain their GFR, their blood pressure was lowered by 5 points on the systolic and 3 points by the diastolic, and their BMI went down. These are a few charts that just show kind of that overall change in the meta-analysis here. And in quality of life for the patients that exercise, we found that their quality of life scores improved dramatically. In our dialysis patients, it was slightly different, though. In the largest study of exercise patients and everything, is called the EXCITE study. They tried to enroll 700 patients, and at the end of the day, only 100 of them completed the full 6-month intervention. In those who completed the intervention, however, a few interesting things happened. They found that patients with their 6-minute walking test increased by about 40 meters in 6 minutes. They also found that their sit-to-stand study, where they sit in a chair and stand up 5 times, they were able to improve that by 2 seconds just by doing this simple exercise program. And all they asked them to do was walk. They got a metronome, they set it at a certain number of beats, and they would walk for 2 minutes. They would sit and rest for a minute and then walk for 2 minutes. They would sit and rest and walk for 2 minutes. A total of 10 minutes in all was all it was, 10 minutes a day. And by doing that, they were able to improve their functionality scores. And most interestingly was the hospitalization-free survival of those patients. There was a clear separation between those who went through the exercises and those who did not. So even our dialysis patients can benefit from exercise. All right, well, maybe you're not a walking person. Maybe you're a weightlifter. So somebody looked at that. They gave patients anabolic steroids and had them weight lift. And they said, what happens? Well, unfortunately, the only thing we saw was that their muscle cross-section improved, but no functional improvement in terms of gait speed, stair climbing, sit-to-stand, those sorts of things. Another study called the PEAK study had both a 12 and a 24-week arm in their study and said, okay, what happens if we have patients do resistance training while they're waiting in the waiting room for dialysis, or on dialysis if they're lifting a weight with their non-fistula arm, or doing leg lifts with those 1980s, leg weights and everything, what will happen? And again, unfortunately, like Bugs Bunny here, things kind of fell flat where the quality of the muscle was better, but they didn't see major improvement in the overall functional scores and everything. So what do I take away from that? Well, again, exercise, I think, in our chronic kidney disease patients and dialysis patients is a good idea. If we can get them into a physical therapist, I think that will be better because they will have that supervised activity. They'll have that encouragement to push through. But again, something is better than nothing. But one of the takeaways from one of the articles that I saw said this. It said, starting an exercise program when a patient reaches the need for dialysis might be too late. It's reasonable to assume that bigger gains could be made by focusing interventions in the non-dialysis CKD patients. So again, that's where I look to you as primary practitioners and referring providers is help us help our patients. Help us get them in and get moving and get the activity that they need. And let it be something that they like. Let them do something rather than nothing. Lastly, I just want to talk a little bit about the quality of life for our dialysis patients. Everybody knows that dialysis is a tough life. It's a full-time job to be a dialysis patient. And what I, as a nephrologist, look at and the government requires me to report has very little to do with how the patients feel or how the treatments make them feel. So what are the things that matter to patients? So there was the Standardized Outcome in Nephrology initiative that was sent out that said, okay, what do patients care about? at the end of the day, what matters to them. And so here's a list of about 20 things, and I just want to highlight a couple of those to prove a point here. So fatigue, restless legs, itching, and sleep disturbance are a few. Here I show the evidence of the efficacy of our interventions, and that the fact that is there an indication in chronic kidney disease? Most often not. We're doing things off-label. We're doing things that we think might help the general population, but that for kidney patients it may or may not work because of their disease pathology and everything. So for fatigue, we try and treat anemia. We try and treat protein deficiency. We try and help them sleep better. We try and help them not have so much anxiety. We try and actually clear their toxins out a little bit better and see if that helps them. But again, at the end of the day, very little evidence or small studies that say we haven't really moved the needle much on the fatigue arm. How about restless legs? Again, no specific therapy using dopamine agents might be helpful. We use a lot of ropinirole in our CKD and dialysis patients and things like that, but there's not really strong evidence, limited evidence that it is effective. Same thing with sleep. We want to make sure we're treating sleep apnea. We want to make sure that they, are tired at the end of the day and that they're not restless. But again, we're limited with our pharmacologic dosing because of their chronic kidney disease. And so really we're left kind of in the lurch in terms of what to do to help our patients with these symptoms. I want to end, though, with itching because we have a new exciting medication that I've practiced 100 times how to say difelikefalin before I came here. It's also known as Korsuva, which is much easier for me to say. But this is a targeted medication against the opiate receptors in the peripheral nerves. And this is finally something that maybe we're able to move the needle and help our patients feel a little bit better with their dialysis therapy. And so this, I think, can set up a pattern for what can we do for those other song symptoms and everything. We identify the problem, we understand the underlying pathophysiology, we then develop a targeted therapy, and then hopefully it works. So again, this is just a cartoon indicating why patients with chronic kidney disease get that uremic pruritus, if you will. High inflammatory state releases opiates or endogenous opioid peptides. Those then leave the peripheral vasculature and attach onto the afferent neurons, which then lead to that sense that they can't scratch hard enough without hurting themselves. And with this medication, they were able to find a twofold increase in patients' itching symptoms, or decrease, I guess I should say. So this is saying the number of patients that had a reduced itching score, and then this is what happened over time. They started on the medication, and over a period of 12 weeks, their itching scores reduced in the two CALM studies. And then by other itching measures and things like that, we're seeing this, the Skindex and some other dermatology thing. But they felt a little bit better. And at the end of the day, that's what we want to do, is help our patients feel better. So in summary, I appreciate most people not falling asleep here. We've talked about some of the dietary guidelines for patients with chronic kidney disease. Those involve the 4 Ps, as I call them: protein, phosphorus, potassium, and pharmaceuticals. And again, I can't emphasize enough, our dietitians are key in everything that we do. So we'll get involved with that. Exercise. Start now. Start before you get chronic kidney disease, but start anywhere along the path because it might be better. And then a symptom approach may help us, at least help our patients feel better, if anything else. Thank you.
Thank you, Dr. Smith. And You read my mind. I didn't have to read the part on this paper that says start to clap. So thank you for that. And now, there is time for questions. Do we have questions? If so, go to the microphones. All right, Dr. Johnson.
So, question about dialysis patients with orthostatic hypotension. So I've got several renal patients that struggle with this, especially on the days of dialysis. So what's your strategy? I mean, I've seen withholding their blood pressure medicines on the day of dialysis versus give them Midodrine day of dialysis or during dialysis. Maybe comment on that, and then also whether Florinef or increasing salt on those days would actually be beneficial or totally avoid that.
Yeah, great question. Thanks, Mark. So the dialysis patient with low blood pressure, I think, is the bane of our existence. Wendy, Javier, maybe you guys can corroborate, but it's extremely challenging because often these patients still have volume overload. They still have fluid that we need to remove during the dialysis session, and so what can we do for them? An interesting thing with that is that hypotension with dialysis, I believe, has an increased chance of mortality, and that has to do with cardiovascular health and other things. We do employ those strategies like Mark talked about, that we sometimes will ask them to hold their blood pressure medications on the morning of dialysis. Sometimes that works. We counsel them heavily on fluid restriction between dialysis. And in fact, I'm a jerk to my patients. I tell them that they should only drink 32 ounces of fluid per 24 hours, plus whatever urine that they make. So if they're anuric, they get 32 ounces a day. And that's in hopes that we'll be able to remove 2 to 2.5 or 3 liters during their dialysis session. It's tricky. There's no one size fits all, and that's where we work as a interdisciplinary team to try and identify those factors. I've used Midodrine and Florinef in my patients. Again, we try and avoid that. In fact, the transplant patients will sometimes use that as a marker for a poor transplant candidate. So we do need to be careful there. And then salt, it's great for somebody with POTS, but for a dialysis patient, again, salt is the enemy. So it will make it so that they have more edema and then, again, more need for dialysis. Honestly, the answer is more dialysis. They did a study on nocturnal dialysis where patients were getting like 8 hours of dialysis therapy at night, and they found that their volume control was much better. We find that our home dialysis patients, those who do peritoneal dialysis or home hemodialysis, tend to do better with their volume status because they're getting more frequent dialysis treatments and everything, but definitely a challenging population there. So no guidelines or specific things that I'm aware of. So,
Dr. Booth?
At what level of creatinine clearance do you start to restrict or suggest restricting protein?
CKD stage 3 and beyond. So when their GFR drops below 60, it's recommended that we start the protein restriction. And as we learned, I think yesterday in the talk, there's also a discussion that we as Americans are probably eating too much protein as well. So it probably even starts before you ever get chronic kidney disease. Yeah.
I appreciated the data you showed about the salt substitute and its impact on outcomes. And that seemed to be using a mix of 25% KCl versus 75% sodium. Do you have a particular product that you recommend to your patients? I'm just looking for mixtures like that. I can find pure KCl online. Is there a mixed substitute, or do patients eat KCl and find that it tastes just as good as sodium chloride?
As one who has tried the salt substitutes myself, I will say that it's more bitter than pure salt. So yes, it does take some sort of mixture. It wasn't pure KCl. In that meta-analysis that I referred to, they found that the more equal proportions of sodium chloride and potassium chloride, the patients had a bigger blood pressure effect compared to, say, the lower potassium chloride within that. I haven't gone, to Smith's or Walmart and said, okay, this brand is better than this one. I just encourage patients to go to the spice aisle and look for the salt substitutes to help guide them with that.
Could you touch on, with the EGFRs, we all know that above 60 is considered normal, but when you look at the stages of chronic kidney disease, it talks about stage 1, normal being above 90, stage 2 is between 60 and that 90 range. Why is it that that's considered mild CKD when the majority of patients are going to be 70s, 80s in a healthy scenario, kind of going up and down, but staying in that situation, and how that relates to BU and creatinine?
Great, yeah. So the question is about the staging of chronic kidney disease, and how is stage 1 and stage 2 not considered need for nephrology referral. Some of that for me is it may be appropriate for a patient with a GFR of 110 to come see me, or a creatinine of 0.8. But if they have evidence of proteinuria or hematuria, which Dr. Morales is going to address next, that's an indication that there's a problem and that they need to be evaluated. Often, the screening labs are just a way to say, okay, we need to get them in the door. So if we see that they have stage 2, GFR of 85, and they're an 18-year-old, that should flag you to say, hey, something's not right there, and investigate that further. Do they need imaging? Do they have, a solitary kidney? Do they have, reflux disease that went undiagnosed or whatever? So there's certain nuances to that. In general, because there are not enough nephrologists in the world. I think we say that the stage 3 marker is kind of the gatekeeper, just so that we can keep up with flows and everything. But I think my colleagues will say, if you ever have a question or a worry, give us a call, send us a referral. We're happy to take a look and make sure that there's nothing to be concerned there. So does that help? Okay, great. Yes.
How big of a problem are oxalates in our chronic kidney disease patients? And do we need to be measuring it or restricting it in food?
Yeah, great question about oxalates. So certainly there are, rare genetic conditions that lead to, oxalosis and oxalate nephropathy. Those are more rare than the exception. In terms of our diets and other things, I think it's a fairly rare phenomenon even in the chronic kidney disease population. But taking vitamin C, eating high oxalate foods can precipitate kidney stone disease. And if there are people who are prone to that because of family history or other dietary factors, certainly we want to be more careful with that. But in the general population, we probably don't need to be as worried. So, here.
When you mentioned supplements, when someone has an unexpected drop in their GFR, I kind of do the standard primary care thing of stop all your supplements, recheck in a week or two. What is the scope of that problem? Like, I know it's a big issue for liver disease. What is the scope, do we know, for all these supplements that people are taking? How much damage are people truly doing in our country?
Yeah, that's a great question. I don't have any statistics on it, but I would say that that's one of the big problems with the supplement industry is that we don't know, right? It's not regulated. They don't have to disclose, what's in their fillers. They don't even have to certify that what's in their supplement is actually in there. And I'll find that, patients who have a long list of supplements, as I go to the natural medicine database or PubMed and everything, I'll find that they're taking supplements that either have no evidence that it's treating what they think it is, or that it actually has some kidney harm, or that, again, there are some fillers and things like that. So, I'm with you. I ask patients, unless there's a clear benefit, and I think that Dr. Grieger talked about a few that had clear benefits yesterday, I ask them to stop those because most of the time it's probably not doing what they think it is. So, Dr. O'Brien?
Yeah, if you have a patient that's stage 3 CKD, which is a lot of our patients, and they're older and they're arthritic, is there any NSAID that it's appropriate to give them? Is there ones that are less or worse than others? And what pain medicines would you recommend for somebody in that case?
Yeah, great question. So what do we do about our patients with chronic pain? I think, the number one answer would go back to, that prevention. If we can, get out and move, exercise. We know from the data that we've seen at this conference here that exercise can help a lot of those things. And even, obviously it's hard to push through pain. I've had severe pain myself and everything, but asking them to try and move, because it really is a use it or lose it kind of situation. For the go-to pain medication, I'd say acetaminophen. And, it's safe from a liver toxicity standpoint to go 1,000 milligrams 3 times per day. With the NSAIDs specifically, it's a class effect. And so all of them have the potential of causing chronic interstitial nephritis. I have seen some small studies that indicate that like COX-1 inhibitors might be less nephrotoxic, but if we were to put a blanket on them, they all can hurt the kidneys. And, every medicine's trying to kill the kidneys.
How about topical? Topical
Topical diclofenac is okay as long as you follow the dosing recommendations. You can get some skin absorption and everything, but as long as you follow the recommendations, you shouldn't get a significant bloodstream absorption of those
Thank you.
NSAIDs. So. Great.
Thank you, Dr. Smith.